Hello, my name is Dr. Brian Monahan, the attending physician of the United States Congress. I would like to speak with you today regarding an update on the novel 2019 coronavirus as of the 25th of February 2020. I have no doubt you have been following this story very closely and have seen my recent video discussion. The novel coronavirus is a virus like the Middle East respiratory viral syndrome and the SARS coronavirus. The natural reservoir is believed to be associated with bats. However, the precise animal reservoir for the current coronavirus infection has not yet been identified. Rumors and misinformation regarding man-made or intentional release sources of the virus are unfounded. The virus began circulating among people in November 2019 in the city of Wuhan, China. As the virus has not been in widespread circulation in humans before, there is little natural resistance to infection. Subsequent person-to-person spread has led to the dissemination throughout China with great social, cultural, and economic impacts in that nation and internationally. The initial attempts to control the spread of virus have focused on tools to limit the travel of people from areas where the virus is present and social distancing to limit the factors leading to person-to-person spread. Although a promising strategy in small outbreaks of infection, like in the SARS infection of 2002, extreme measures of containment have not been fully successful in the current coronavirus outbreak. Since the time we last spoke, there have been some new developments. There is a new name for the disease caused by the novel 2019 coronavirus. The disease that it causes is called COVID, COVID-19. COVID-19 is the name of the disease people get when they're exposed to the virus. There is a new name for the virus. It is now called SARS-CoV-2. That's capital SARS-CoV-2. The coronavirus has now spread to more than 33 countries and territories. Many of these cases have no known link to China. There is no reduction in new cases yet, and new countries continue to emerge. South Korea, Italy, Iran, Lebanon, and Canada have been added to the list and are now facing growing difficulties. We are not seeing community spread in the United States, yet it is possible, if not likely. So far, there are at least 39 cases in the United States. There are no known cases occurring in the region of the District of Columbia, Maryland, or Virginia. States with disease cases include Washington, California, Nevada, Texas, Wisconsin, Illinois, Nebraska, and Massachusetts. The Centers for Disease Control has suggested more cases are likely to be identified in the coming days, including more cases in the United States. It is also likely that person-to-person spread will continue to occur and may occur in the United States. Widespread transmission of COVID-19 in the United States would translate into large numbers of people needing medical care at the same time. Schools, child care centers, workplaces, and other places for mass gatherings may experience more absenteeism or temporary closures. Public health and healthcare systems may become overloaded with elevated rates of hospitalizations and deaths. Other critical infrastructure, such as law enforcement, emergency medical services, and transportation industry, may also be affected. Healthcare providers and hospitals may be overwhelmed. At this time, there is no vaccine to protect against COVID-19 and no medications approved to treat it. Non-pharmaceutical interventions such as social distancing, ill contact avoidance, surface decontamination, and hand washing would be the most important response strategy today. This particular coronavirus threat has many distinctions compared to what we have seen before and is unlike the previous SARS infection in several important regards. There is persistence of infectious particles in droplets on surfaces, and this can depend upon environmental variables such as temperature and humidity. Some reports have cited infectious particles as long as 9 days persistence. This coronavirus has high levels of viral replication in the nose and throat, facilitating its spread. For example, a woman attending a church service in South Korea infected 231 fellow parishioners, now with 556 total infected people in South Korean outbreak situation. Infected people can transmit the infection in the absence of appearing to be ill. Methods of airport screening to detect fever are not effective. Overall, this coronavirus is less deadly than SARS, but more contagious. It has a wider spectrum of severity, from asymptomatic to minimally symptomatic to severe illness. The risk to individual is not easy to predict. Traditional groups who have had trouble with infections of respiratory disease in the past, such as the elderly, those with certain chronic illnesses such as lung diseases, asthma, or immune suppression, do not fully account for the observation that many people without these risks develop severe illness. Healthcare workers have seen a particular hardship with transmission of disease and affecting their numbers. There are increasing secondary effects of care for infected patients demonstrated by China and other countries, which leads to the reduced availability of healthcare services for other patients, such as those needing surgery, cancer chemotherapy, or dialysis, become problematic in their ability to receive care. There are many reports of stigmatization of entire groups of people based upon their race or national origin, leading to additional hardships in daily life for these people in those regions. Scientists have increased attention also to the intestinal replication of the virus and possibility of spread through stool samples of infected persons. Fortunately, there are no food-borne cases yet, and the virus is neutralized by normal cooking procedures. Many of you are certainly familiar with the cruise ship experiences, such as the Diamond Princess and its 3,771 passengers I mentioned to you on the last video. On the 1st of February, an 80-year-old man left the ship and became ill with coronavirus. 7 days later, 16 people on the ship were ill. 16 days later, there were 454 ill persons. On day 16, the United States evacuated 328 asymptomatic people, 21 of which later proved to be positive for the virus. 18 days later, there were 621 ill passengers from the ship exposure. In discussing the coronavirus enumeration of cases, we're still hampered by data limitations. The case definition is changing. Recently in China, the case definition has now included people with chest X-ray findings of certain infiltrates that don't have positive laboratory testing would be considered to have the disease. Most countries lack the PCR test capabilities to detect the disease, and this leads to massive undercounting of infected people. For example, most maps show no disease activity in the continent of Africa. Few believe that is accurate. Lack of transparency issues persist due to issues of stigmatization of identified groups and nations. In China alone, there are greater than 77,000 cases and greater than 2,200 deaths. Many people are concerned with the chance of death from acquiring the coronavirus infection. In discussing the statistical risk, precise use of language is critical. The symptomatic patient mortality risk, known as the case fatality ratio, is not precisely known, but may be approximately 2%. This is compared to 0.1% for influenza, or 23% with the previous experience of the MERS coronavirus. The mortality ratio that includes all the number of people carrying the infection, with or without regard to symptoms, may be much lower, probably 0.3 to 1%. Generally speaking, you could view this COVID-19 illness as a much worse situation than influenza, but not nearly as bad as SARS. 1 to 2%, however, should be considered a very significant mortality rate and will lead to considerable burden in our healthcare system. Additional information is becoming known from the study of those who become ill from acquiring the disease. This is called the natural history of the infection. The incubation period from the onset of exposure to the virus to the development of symptoms is approximately 4 to 7 days on average. It may exceed 14 days in some patients. Approximately 80% of people infected become ill with a mild infection and then they recover. The vast majority of people recover from this infection. At the end of the first week, among those who are ill, 1 in 7 develops pneumonia, characterized by difficulty breathing and other symptoms. During the second week of their infection, the body's immune system then responds to begin destroying an innocent bystander effect of their healthy lung tissue, causing ongoing issues with organ dysfunction and lung dysfunction. 5% of those with pneumonia have critical illness, including respiratory failure, septic shock, and multi-organ failure. Scientists around the world are studying possible treatments for the virus, and there are developments in exploring these therapy options. China is leading the scientific endeavors to test therapies in randomized controlled trials utilizing the large number of available patients that they have. Effective therapies could lead eventually to a preventive therapy. Examples under consideration but not yet proven include an oral HIV drug known as Kaletra, investigational intravenous antiviral drugs, for example, remdesivir, or injections of antibodies from the plasma of surviving patients. There are viral-specific cells derived from the blood of survivors, and other use of chemicals which interfere with viral replication, such as beta interferons, now under study. In the future, a vaccine will be developed, but this will require time to manufacture, test, and distribute, and then prove its safety and effectiveness. What can you do now in your workplace? First, understand the importance of effective risk communications. Understand the importance of this in engagement of our capital community. One of the most important and effective interventions in a public health response to any event is to effectively communicate what is known, what is unknown, and what is being done to get more information, with the objectives of saving lives and minimizing adverse consequences. Effective communication helps prevent infodemics, meaning an excessive amount of information about a problem that makes it difficult to identify a solution. It also helps to build trust in the response and increases the probability that health advice will be followed. It minimizes and manages rumors and misunderstandings that undermine responses and may lead to further disease spread. Regular and proactive communication and engagement with the public and at-risk populations can help alleviate confusion and avoid misunderstandings. An important issue to consider is that an individual's perception of their risk may be different compared to that of experts and authorities, and effective communication can help bridge that gap by determining what people know, how they feel, and what they should do in response to disease outbreaks, as well as what they ought to know and bring the outbreak under control. You can promote avoidance of infection, such as avoiding close contact with people suffering from acute respiratory infections. Ill individuals should stay out of the workplace until they are recovered. Frequent hand washing, especially after direct contact with ill people or their environment. People with symptoms of acute respiratory infection should practice cough etiquette, such as maintaining distance 3 to 6 feet, covering coughs and sneezes with disposable tissues or clothing, such as coughing into an elbow rather than onto a hand, and frequent hand washing. Within healthcare facilities, there is need for enhanced standard infection prevention and control practices in hospitals, especially in emergency departments.